Welcome to everybody. Our monthly webinar today is with Michal Hason Rozenstein. The presenter is very important because she is a clinical psychologist, very well trained. She presents a very innovative topic, the third wave of treatment for eating disorder. And nowadays, she is the president of the Israeli Association of Professionals for Eating Disorders. And so we are here to learn by Michal. Thanks, Michal, for your presentation.
Thank you. So I'm very excited to be here, and I hope it will be interesting. I am going to talk about third wave treatments for eating disorders. I'm not going to talk about all of them, but some of them. Well, let's start with why do we need them? We need different therapy for each patient because they're all different people. And what the third wave therapy offers us is mainly creativity and flexibility. And these are two characters that are very important for eating disorders. Usually, when we speak about the third wave therapy, we're speaking about what we usually know, and of course, my presentation is stuck, which is mainly DBT and Schema therapy. And I don't know why, but my presentation is not working. I will stop sharing it and test it now. And I will have to be flexible and creative to see why it's not working. Okay, it seems like it's working now, but only when you don't see. Let's do it again. Let's try again. Okay, no. Okay, dialectic behavioral therapy, I'm not going to speak about it a lot because you all know it, it's very common. Usually DBT specifically targets the deficit in emotion regulation by teaching the participants a few skills: mindfulness, distress tolerance, interpersonal effectiveness, and just learning how to cope. We also have the compassion-focused therapy, which is a model that recognizes self-critical natures like shame experience that we all see in eating disorders. I'm not going to talk about it a lot, but it is a part of ACT and EMDR, which I am going to speak about more in details. We have the mindfulness-based interventions that are very, very popular in recent years because it makes people with eating disorders feel themselves, feel their body, which is something that that can be very difficult for them, especially if they hate their bodies. So we can let them look and experience their feelings with no judgmental fashion, with not being judgmental and not being avoidance and not trying to feel ashamed or punish themselves. We have schema therapy, which I'm not an expert in, but I do use some of these models, especially some of the techniques like chair techniques that allows us to speak to the eating disorder. And what I am going to speak about more in details is acceptance and commitment therapy, which we call ACT, because it is a behavioral model. It involves psychological flexibility, like being mindful, aware. It makes us accept who we are and accept our feelings, and more details are coming. So I choose this picture because in this picture, I think it's a bunny, I don't know how it's called, Well, in the story of Alice in Wonderland, they keep chasing time. And it doesn't matter how fast you run, you always stay in the same place. And sometimes it feels like this in treating eating disorders. You have to run as fast as you can, as work as hard as you can, just to remain in the same place. Because if you stop running, you just go back. So this, I think, describes working with eating disorders. So what are the main ideas of the third wave treatments? First, it's adjustment. We have to adjust the treatment to the patient and not the patient to the treatment. We find that a lot in hospitals or when we have group therapy, that everyone has to get the same treatment. However, third wave treatment says, okay, each patient is different and they need different focus in their therapy. We also use mindfulness to thoughts, feelings, and sensations and emotions. Acceptance is also a main idea because some things can change. Some things we have to work hard just to stay in the same place. Sometimes it doesn't matter how hard we try, we will have the same body or the same feeling or the same parents. So we have to accept it. Flexibility is the main idea. Like we have to find a way to do it. If it doesn't work this way, we have to think about a new way, just not do over and over the same and expect different results. So we have to be flexible. We have to think about our borders. We have to think about the symptoms and we have to think about the patient and what will help them and also be helpful for us. So how does it work? I chose here the picture of Elsa, who had, if you know the Frozen, I guess you all know the Disney video, Frozen. She thinks about let it go, just accept who I am. Instead of running for myself, I have to accept who I am and just let it go, let myself be who I am. So flexibility and reprocessing of information and automatic thoughts. We have to think again and again about how our mind works, how our memory works, and the patient, of course, and reprocess the ideas. We have to deal with frustration, self-acceptance, sense of choice. Sometimes people with eating disorders think that they choose the eating disorders, however, they don't choose it. They do choose other things. So they are not to blame for their eating disorders, but they do have to take the responsibility for treating it. Symptoms-focused treatment while relating to personal dynamic and past traumas. So we have to think about who is the person, what is her history, what did she try before, what previous treatment she tried. Work for eating disorder due to the ability to create relatively fast changes in parallel to deeper mental process. So it helps us because we can do both. We can stay in the present and work with the symptoms and also seek for the past and process trauma or deeper insights. It allows us stability and some progress, even in the most difficult chronic cases. It can help even patients who are sick for 40 years. It makes them more stable, even though it doesn't always heal them. What about the therapeutic relationship? I'm a psychologist, so this is something we speak about a lot. Treatment requires flexibility from the therapist side. If they can't come at 7 because it's their mealtime, then if I press them to come at 7, they will just stay home and they won't come and they drop off and they drop out of treatment. So at least at the beginning, I have to be flexible. I have to see what they can do and what they can't do, because I can't ask them to do something that they can't do, at least for now. Setting should be stable, clear, and flexible. It's like having a flexible walls. You need them, but you need them flexible. You can't just leave them without any boundaries and no setting at all. It has to be very clear, but we also have to keep in mind that it is hard for them. The motivation conflict, understanding the meaning of the eating disorder as an avoidance mechanism against negative feelings. If we know and we can understand why they choose the eating disorders, they don't really choose it, but they have to use the eating disorder, because if they don't use the eating disorders, then they suffer really, really hard from something else. Sometimes it's easier to think how much I ate or how fat I am than thinking about the trauma, about my parents hating me and other stuff. We progress together. I have to tell my patients, and they have to feel it, that I am on their side. Sometimes patients, especially patients who already been in treatments or hospitalized, they feel like they have to fight the therapist because they have to maintain their eating disorders and not let anyone touch it. So I have to convince them that we are all together and we are working for them. Okay, now let's go into ACT. I chose this picture, if you know the movie, Inside Out, about sadness and happy. Because when you are sad, you can't just keep your sadness in a cycle. When you're sad, it goes everywhere and you can't control it. And even though we try to keep our sadness like closed in a box and not feeling it, it will always go out. This approach is developed from the CBT with acceptance and mindfulness. We should be ready to accept things we can't control or that the price isn't reasonable. If I want to be thin and I want to be in a lower weight, then maybe I can't do it. And if I do it, I may get very, very sick because it doesn't fit my body. The ability to accept negative emotions. I can be very sad and very frustrated, but there is nothing I can do about it. I am just going to be sad and I'm going to be frustrated, and it's okay. This is a part of who I am. This is a part of life. I just don't have to get rid of these emotions. They are part of me. They need space. Stephen Hayes, Kelly Wilson, and Kirk Strosh are the developers of this approach. Okay, let's look at this. ACT is about psychological flexibility. The opposite of inflexibility is that we often see eating disorders. They are not very flexible, I have to say. They eat something or they don't eat something, and it has to be in a certain plate and certain hour, and it's only if it's red enough or white enough, not flexible. So we have to work about make them more psychological flexible. And we do it by, we have to focus on present instead of past or future. Like, I used to be fat, I'm afraid I'm going to be fat, okay, but now I am okay. I just have to deal with this one meal. I don't have to think about previous or forward, just staying present. I am not going to teach you ACT, of course, in this 60 minutes session, just to show you that it exists. We look about ourselves in a context. Like, we change, we are people, we respond to things, we react to things that happen. We don't have to be the same all the time. There is a core of what we are and who we are that we take with us everywhere. But we do change according to where we are. We are talking about acceptance. Like I said before, we have to accept our feelings. If we try to avoid them, then they just come back all the time. And we waste a lot of energy, a lot of mental energy, just to not feel them. We have to accept them. It's there. We can be afraid, we can be angry, we can be sad, it's okay. On the other side, we have values. Why values? Values that takes us where we want to go. Like, I want to be a friendly person. I want to keep the environment clean. This is who I want to be. As long as I can accept my feelings, I can follow my values. However, if I want to be a healthy person, but I'm too scared to eat, then I follow my fears and not my values. We are talking about diffusion, which means like, okay, if I'm fat, then everyone hates me, so I am miserable. I am bad, I am ugly, I am rejected. This is all cognitive fusion, because if I'm fat, it doesn't mean that everyone hates me, right? And so we have to make the diffusion of this thing so we can accept ourselves better. And this leads us to the committed action. We want to act. We want to do what we believe in. We want to behave and act according to our values, not our fears, not our avoidance. We want to act in the present, not in the past. And we have to act according to what happens around us. And keep in mind that it doesn't make us something else. I know it's complicated, but I hope you get the idea. We have to learn how to look at things differently. Focus on here and now. Accept negative feelings. We should have more tolerance. We call it the window of tolerance. We have to feel some stress, but not too much, because if it is too much, then we can't have it, then we lose it. We get too anxious, too angry, too sad, and this is not what we want. We want to have a large window of tolerance so we can deal with many stressors, but not too much, of course. Accepting myself, including history, genetic, past trauma. We have to move from, I can't accept myself like this, that sometimes we hear from people who gain weight, I can't accept myself like this. And we have to go to, this is me now. Maybe I will change, maybe I'm not, but I can't just not accept myself because this is me. I can hate myself, but I have to accept it. So we go from denial, which we see a lot of eating disorders, a lot of denial. I'm not really sick. You are all sick. Why do you make me eat? You don't understand. My body works differently. So this is denial. So we go from denial to accepting the disorder. Only when you accept the disorder, you can start treating it. Sometimes you think that people choose the disorder, however, they don't. And we all, as a society, as families, and as patients, should be accepting it as a defense mechanism. It's just easier to use the symptoms to protect ourselves, but it's not really a choice. Instead of feeling guilt and self-punishment, we have to take responsibility. Instead of judgmental, we have to be pragmatic. We have to do something. This is also sad, and she is too sad to walk. And now she can't walk, and she needs some compassion. So it's extremely important for eating disorders. It is okay to be me. And my presentation is stuck again. So to make it interesting, you have to see me until I release my presentation. I hope I can do this. Okay, it seems like it worked. Now you won't see me. The slide, I hope. Okay.
Okay, starting again.
No, it's not working. I don't know why.
It's a way to breathe together. Huh? We can take a minute. It's
Yes.
a break together, and so it's a way to
It's
take,
okay.
to stay more relaxed, as you said. Flexible.
Yes, we will
Flexible and
relax. It's okay. And we have some self-compassion about the technical difficulties. So it allows a safe place to be me, to be in. I can be mentally safe, even if something doesn't work, like this presentation. It's okay, I'm still safe. I can do this, I can handle it. It does stress me, but I can still do it. It allows a sensitive observation of the internal sensation and experience without judgmental and criticism. Stuck again. I don't know why it doesn't work when I share the screen. Every time I share the screen, it's stuck. Okay,
yeah, it's a way
now it worked.
to exercise together.
Huh? Yes. What's a commitment? Who is commitment? At home, at hospital. Sometimes commitment is not something we see in eating disorders. It's like the environment is committed, but not the patient. She wants to be fed, like she needs to be fed. She needs someone to like force her to eat. Sometimes it even makes her calm because she doesn't have to choose. But commitment is kind of a reality check. I have to accept I have a problem, and then I can be committed to treatment. And commitment changes during the treatment. Sometimes commitment can just show up. You don't have to talk, you don't have to do anything, just show up. And it's fine for the beginning of treatment. But later on, I will expect her to speak or eat. And if she is in a bad condition physically, then she'll have to eat right from the beginning, maybe in the hospital. However, it is a process of taking responsibility. We can't just tell her, okay, now you have to take the responsibility and be responsible for your health. It's a process, and we share the process. It is our shared responsibility to do it. We have to be open to experience and healing. Feel it, be afraid together, trust the therapist. Sometimes they don't trust the therapist. The therapist is a bad guy because they asked me to eat and they forced me to eat, and they threaten that if I don't eat, then they'll take me to the hospital, and I can't trust them. So this is hard for both of us. And again, I have to be very creative to make them trust me and say, okay, we are on the same side. Joint commitment. So let's look at this. Like, I am fat and useless, okay? I don't know if I want to be healthy. I can't even think about eating that. I can't accept myself like this. Each one of them presents something. Like, I'm fat and useless can go to diffusion or self as contact. I don't know if I want to be healthy. She asks about her values. Do I want to be healthy? Is healthy something I believe in? Do I want it? Maybe I'm just too scared, which is the emotions. I can't accept myself like this. This is acceptance. I can't even think about eating that. I can't even imagine that. This is also psychological flexibility. I don't ask you to eat it. I'm just asking you to think about it. And sometimes it can be too hard for her just to imagine that. And this is also the psychological flexibility we work on. No one will love me is a great example for diffusion or cognitive fusion. If I eat, then no one will care for me. I'm not be sick anymore. My parents won't take care of me. I am okay like this. Don't make me gain weight. What is this? This is avoidance. Okay, I don't care about reality or reasonable. It's okay, I'm okay, just leave me alone, I'm fine. There are some research that show that ACT can work. There are not many studies yet. However, there are some. Most of them show that eating disorder characteristics react to ACT. However, not many studies actually checked ACT. There are some. So we can see that avoiding negative feelings is described in eating disorders. ACT refers to this issue directly, along with inflexibility. So we can see that it really, really works. Cognitive flexibility allows dealing with motivation problems that is a symptom of eating disorders. Focusing on values and meaning reduces the helplessness feeling that we see a lot of. ACT was found to have similar treatment outcome as other treatments, but less readmissions to hospital within 6 months. One study from Sweden shows symptoms reduction that sustained 2 years for a group therapy. However, not many studies yet. Okay, I'll take a breath now. And now when you understand main ideas of ACT, we will go to EMDR. Maybe some of you already know EMDR. EMDR was developed by Francine Shapiro to treat trauma. They say that trauma creates maladaptive memory networks with present triggers. Like we remember the trauma and we remember ourselves in the trauma, and we remember ourselves like weak or helplessness, or sometimes a shame, or sometimes guilty, or sometimes lose it. So we build the whole memory around our experience. So the EMDR focus on changing this experience. It doesn't change the memory, but it changes how we feel about the memory. We walk, like you see in the picture, like, okay, we have to move your eyes. Why? This is something that was taken maybe even by mistake, but from REM sleep. When we are asleep and we process information, our eyes move. And studies showed that making the eyes move make the same, maybe not the same, but similar process that makes us process memories and thoughts. So reprocessing the memory allows us to create a new experience. So the basic terms are negative cognition, NC, a negative perception and beliefs that a person has on herself. Like I'm ugly, I'm disgusting, I don't have any control of myself. The NC was created during a traumatic experience, usually. Sometimes it's one event, but many times it's a lot of events. Sometimes it's complex trauma, sometimes it's simple trauma. However, it makes us think bad things about ourselves that stay with us. Like I am weak, I am useless, I am ugly, I am stupid because of something, like the children hated me and I was a victim of bullying, whatever. We also have the positive cognition, a positive belief that something I believe about myself, like I can be creative, I deal very good with stress. It can also be I like flowers and I like looking at the sky, whatever makes me feel good. It is usually the opposite of the NC, but not necessary. Like if my negative cognition is I am weak, then I will try to think about a memory in which I felt strong. But not always, and in eating disorders and complex trauma, finding the positive cognition can be very hard. So sometimes we don't have a positive cognition. So instead, we just say, okay, I'm okay now in this moment, I can deal with it. And that should be enough for the positive cognition. Because for people with complex PTSD, it's very hard to find something that they really feel positive about. Because even if they think, okay, I'm friendly, then in a minute they remember something bad about their friend. So it doesn't stay positive for a long time. So we only focus in this moment, now I'm okay. It can be I'm strong, I'm okay, I can deal with it. We check for SUDs, subjective unit of distress. Like when you look on the plate and you have to eat the bread, how stressed do you feel? How distressed do you feel from 0 to 10? And we can check these changes. During the process, we expect the SUDs to reduce. Sometimes they go up and we have higher level of distress, usually in cases of avoidance, because if I have avoidance, then I don't feel any distress. If I can't imagine the plate, that I don't feel any distress. But when we go into it and we do imagine the plate, we feel the distress. We can do it about memories, and we can do it about the present. This is what I like in EMDR for eating disorders. I can work on the past and present and jump from them. Okay, we have the window of tolerance here, as I explained before. The amount of distance I can take at the moment. I can imagine a plate, but I still can't imagine the bread on it. Okay? Then we will add the bread and see how much distress it causes you and how we can reduce it. Every time I ask her to think about it or get a new association, I tell her, okay, look at my finger. Then I take my finger off and say, okay, what is your new association? I don't know why it works, but it works. And it makes the distress level change, and things that she couldn't even imagine at the beginning of the meeting, she can go and eat after she leaves. I don't know why, but it works. When we are in the window, we can handle it pretty adaptive way. We have this is like an art to find the window. We want her to be in distress, but not too much. We don't want her to be avoidance, and we don't want her to be too anxiety, and we don't want her to be dissociative. So we have to work all the time, like keep her distressed, but not too much, and then calm her down and then push it. So it's like an art.
And can you share your screen, Michal?
I share my screen, don't I?
No.
You don't see everything I show you?
I don't look at
Really?
it. Really?
Wow, then you missed a lot. I didn't even know.
Exactly.
Sharing my screen.
You explain so good.
Now you see my screen?
Okay, now, exactly. Now it appears.
However, when I share my screen, then, okay. So we can process the somatic, emotion, and cognitive experience. So you didn't see the ACT star at all?
Yeah.
Okay, maybe I will go back to it later. So
Exactly.
you see how it looks like. Okay, we have to change the experience from the impossible tolerance to possible, reducing the effect of triggers in everyday life. Like you don't want to break down because someone offered you a cake, okay? We can, okay, now the picture here shows you a different way to work with EMDR. We can also use like in a butterfly mode and tap our shoulders. Triggers are connected to eating behaviors and getting control and getting weight. Not always we can reach a specific memory of the trauma, because many of the patients with eating disorders also suffer from trauma that was what caused the eating disorders. Not always we can reach it, not always we can get there. However, we do get the sensation of what started it. When I share my screen, then my presentation doesn't work.
Exactly.
But when I
it
don't
disappears
share my
again.
screen,
It disappears again, your screen.
yes, I know you can see me now, but it's stuck. Happens over and over again. I don't know why. Okay, let's try again. Maybe if I stay out of presentation mode, it will be better. I know it's not the best,
okay,
but we can try this too and see if it works. Okay, we have the negative experience paradox in eating disorders, because when I don't eat, I feel pretty good. But when I eat, I don't feel so good. So I don't want to eat. So if I ask her about her distress, then she says, okay, I don't care. Like, it's different from other trauma treatment or anxiety treatments or depression treatments, because those people want to get rid of their distress. But people with eating disorders, they found a great pleasure of handling and controlling their negative experience by using eating behaviors that are not that adaptive. So we have to talk about what's called the LOPA, level of positive affect, because they just don't want to change their behavior, which is kind of similar to OCD. I found something that makes me calm, so don't take it away from me, please. But I am going to be bad and I'm going to take it away from them because it's not good for them. Like it makes them feel good, but it's not good for them. And they know it, but they can't control it. And they have to accept that they can't control it. We're also talking about the level of urge to enact the maladaptive and enforcing eating behavior. We want to reduce the urge, and we actually want to reduce the level of positive affect. I don't want them to feel so good when they don't eat or when they have a bulimic episode. I don't want them to feel good. I want them to feel bad about it. And they say, okay, come to treatment, and then I feel bad. I don't want to come to treatment. So we have to keep in mind all the time that beyond the symptoms, there is something that wants to get better, something to fight for. Even if it raises a SAD, sometimes I tell them, okay, now you feel safe. You're standing in this island in the middle of the ocean and you feel safe. But you're stuck. You can't go anywhere. If you want to get somewhere, you have to get in this mud. You have to get in the water. You can just keep standing there. You are safe there, but you are not getting anywhere. When Beerger actually started the first protocol for EMDR treatment in eating disorders, so we work mainly, at least in the beginning of food treatment, on the desensitization. Again, okay, like just picture this bread you have to eat, look at my finger, okay, it scares you, okay, now maybe less scares you, until we can reduce the level of positive effect from not eating and reduce the level of urge not to eat and increase the subjective unit of distress, but within the window of tolerance. You have to be distressed. You can't just be calm. If you have to deal with something that scares you so much, we don't expect you to be calm. While increasing the window of tolerance, of course. We have to use the PC the positive cognition, like I can tolerate it. I am okay. I can do this. I am not expecting her to be happy and feel strong when she eats, because she feels weak. She has a voice in her head that tells her, okay, if you eat that, it means you're weak. You're letting it go. You're letting yourself go. And she has to tell herself, I can tolerate it. And we walk. I can tolerate this. I can do this. So we have to keep don't distract, handle, use a safe place. Think about something that makes you feel okay. This is a picture from Italy. Okay, so what are the benefits? It's allowed processing of traumatic events that are connected to the developing of the disorders. Sometimes we can start working with a stimulus who is a plate with the bread, and she can remember her childhood, and if someone made laugh of her, and if her parents ignored her, and then we can go to the past and like clear the trauma, process the earlier trauma. If the trauma is more complicated, then it repeats itself. So we have to process it very carefully and slowly. However, it allows us to stay in the present and in the past, which is, as I said, extremely important for eating disorders. For a dynamic treatment, we can stay in the past and talk about the past for 5 years. But with eating disorders, if we talk about the past 5 years, after 5 years, I don't know if our patient will still be alive. So we have to always be present. Okay, and it's stuck again to make it interesting. So you'll have to see me again.
Yeah.
Just said, okay, this is EMDR, look at my finger. I will try to make my presentation work again. Okay, and now it's working. I don't know why, but it's working, like EMDR.
It's working, okay.
Yeah, I don't know why, but okay, it allows present work by reducing the sensitivity to current triggers and making eating and weight changes more tolerable. Again, she won't like her body, but she can tolerate it. We don't replace bad memories, but we can look at them with a compassion and strength, saying like, okay, I'm here now, I'm safe now. I can judge myself of what I was in there. Of course, everyone would do this. Change the way we look at ourselves and reduce the power of the negative cognition. I don't know why, but every time I have to change slide, I have to stop the screen.
Exactly. At every steps, you lose the connection with your screen, and so you can reintroduce your screen.
Now everything is stuck. Also in my screen.
Hopefully, we don't lose our memory, because if we lose our memory,
no, we don't lose our memory, and we can still talk about
cognitive.
it. Okay, so I'm going to share my screen again, and this is how we're going to do it. As we said, we have to be very flexible and creative. So we have to deal, in eating disorders, we have to deal with denial, resistance, denial, resistance, denial, resistance, and it can take years. We do need to take narrow and, I think I had a typing mistake. We have to be a flexible window of tolerance. Extreme anxiety from gaining weight that hides the more deep fears that we can address often. We can find them. If someone says, okay, I'm afraid to gain weight, we have to look for her negative cognition. Why else you are so afraid to gain weight? What does it mean? It means that I can control myself. Okay, that can be very, very scary if you can control yourself. Let's speak about your control sensation. Or everyone will hate me. Okay, so let's speak about that. Everyone will hate you. We are making the diffusion again. everyone hates you, but doesn't have any connection for you getting another 500 grams. And we deal with the history of negative events and experience with body image. Usually it comes from the family. Like the grandparents say something. And again, you have to see me because the slide doesn't work.
You have to
Eventually it will work. Okay. Next slide. Oh, maybe it's good. You get to see me also and not just the slides. Okay, so also in EMDR, there is very little research is available for eating disorders specifically. However, it is a promising since there are successful common similar disorders such as complex PTSD and OCD that have a very good outcome. So we do believe that we can get very good outcome for eating disorders as well. So summary. And then I remember I have to go back to the ACT style to show you. We have to be flexible. We have shared responsibility for the patient and the therapist. Increase the ability to deal with negative emotions and conflict. Acceptance, compassion, adaptive choices for both patient and therapist. We have to always look at ourselves as well. This is my email, and you can use it if you want to ask any questions. However, I do want to go back to the ACT star, which I now understand you didn't see. So you have to see me again until I can get there and get my presentation work.
Thanks a lot. Your presentation was very good. You open a very large opportunity to discuss and to reflect, and so you can stay some minutes here to.
Of course, and I wanted to show you the ACT star. You didn't see it before, right? You just saw me talking about and showing you and presenting and pointing stuff, and you didn't even see. And you didn't see all the beautiful pictures I put in. So just look at this star. This is the ACT star. It is about psychological flexibility. Okay, just all the things I spoke about before, now you can see them. The present, self as context, values, diffusion, acceptance, and committed actions. This is how it looks. And the psychological flexibility is in the middle. All of them around create the psychological flexibility and allows it. Once we have a psychological flexibility, we can change the eating behaviors. We can change the symptoms. We can feel much better. And now I will stop sharing and I can open it up for discussion and questions.
Yeah, thanks a lot, Michal. Just a question. One question is about some effectiveness in the short and long time.
As I said, in short time, there is no much research about EMDR and ACT in eating disorders. However, what we do have says that it can reduce hospitality, especially ACT. EMDR is more complicated for research because usually it's not the main treatment. ACT is also not always the main treatment. But there is no straight protocol for eating disorders, so it is hard to study. However, patients do report reductions of the urge to do their symptoms. I can have patients in my clinic going out and then eat their meal and say, okay, it was okay. It wasn't as scary as I thought so. We do have very good outcome treating complex PTSD that involves eating disorder and self-harm behaviors. Then we process the earlier trauma, and it allows people in the present to reduce their symptoms. There are very good outcomes, as I said, in OCD, in short term and long term. Most studies don't follow up more than 2 years, but in 2 years, there are good outcomes. I hope that there will be more study and control study, even though it's very hard to do this. Because as I said, when your protocol is very flexible, then it's very hard to do a study because each patient gets something a little bit different. And then it's very hard to study groups because they are different from each other. I guess there is something there are a lot of case studies that show very good outcomes.
Thank you. Can I ask something like this? When some people is exposed in the early stage of the development to very extreme experience that he is named ACA, the adverse childhood experience, they memorize, but they memorize in the implicit way. And so you can't discover the reason of the trauma. What you said about it?
I can discover it, even if it's not verbal, especially EMDR can be very not verbal. I just tell them to focus on something, like I look at my plate and my stomach hurts. Or I remember the tree in front of our house and my head is about to explode. So they don't need to have the memory, but the body remembers. The body, it's like the book, the body keeps the score, if you know this book. The body remembers and the body reacts, and EMDR allows us to walk about these memories even without remembering them. Just tell her, okay, just focus on your sensation. If you have like pressure in your head, just focus on the pressure and look at my finger. Okay, and then sometimes it raises memories, sometimes it doesn't. But it does change the experience because after a while you can say, okay, I don't feel my head anymore. Now I feel my stomach, or now I don't feel anything. Now I just remember something else. Just remember my lunch yesterday. I don't know, but it changes. It makes a change in how we feel, and we don't need words. We can also walk with teenagers who doesn't want to walk. I just tell, okay, just think about it and look at my finger, at my pen. You don't even have to tell me what you think about. Just tell me if something is different, if you feel any difference, any change. That's it. Okay, don't tell me what. Just let's continue. Just look here.
Thank you, Michal. Everybody can put this question inside the chat box. We have some minutes. ACT, Michal, is, in my view, a way through the well-being as said World Health Organization. And so you have to stay, if you are in well-being, quiet, relaxed, and safe in yourself. This is a best balance for you, and so you can manage your emotion.
I do acts to myself all the time. All the time I have to think, okay, what are my values? It's like a way of living. Yes, I like it very much. You can adopt it yourself. We can all do.
Some questions, some other questions. Otherwise, I want to underline that Lazarus, some decades ago, in the 96, spoke about the basic ID model, when the question is use every model of therapy if it works pragmatically with your patient. So you have a large in your pocket number of tools that you apply appropriately. You agree?
I have a lot of techniques. I don't like the word tools because when you speak about tools, you always think about, like I'm thinking about tools, like you have to build a house or fix something. I don't know why, but I do have a lot of techniques and I try to use them and also use the tools, but I have to adjust them. And this is why it calls like eclectic treatment or integrative treatment. because we use all of them, which also makes it very hard to study, to do research, because if you use some of this and some of this and that, then you can't study it. You can't make a control study.
Okay. And so today we learned many things, thanks to Michal, both for your content and your style of presentation. I want to thank, as always, Elisa Meyer and Don Gannon. They are the very important shoulder for the European chapter, and so thanks a lot for your support. And thanks to everybody, because today we have to learn by Mika, many thanks, to reflect and to enlarge our experience. Thanks. We'll meet together next month in the next webinar organized by the European chapter. See you again, and thanks, Elisa, thanks, Don, and thanks, Michal. I'm happy to stay with you. Ciao. Ciao to everybody. Okay.